Looks like it's noontime, and I want to get us started because we have quite a large panel for this discussion today. And, it's such an important part of our continuum of care is the connective tissue that connects folks from the immediate crisis to treatment. And so we really wanted to make sure that we have a robust conversation. So I'm going to get this show on the road. Y'all, good afternoon. Thank you all for attending and welcome to Live Tampa Bay's Link Lunch and Learn webinar. My name is Jennifer Webb. I'm the Executive Director of Live Tampa Bay. And as we get started, for those of you who are just joining us, please add your name, organization, and email address in the chat so we can be sure to follow up with you. If you are joining us for the first time, I'd like to briefly tell you about Live Tampa Bay. Live Tampa Bay is part of a statewide initiative funded by the Florida Blue Foundation and brought to the Tampa Bay region by the Tampa Bay Partnership. The goal is to bring together business, faith, and philanthropic leaders alongside the traditional frontline professionals with really one goal, which is to reduce the number of opioid overdose deaths in the Tampa Bay region. And we seek to do this through a collection of interlocking efforts, including advocacy, education, and collaboration between the business community, frontline professionals, and members of our community committed to saving lives from the opioid epidemic. Our focus for this webinar is the focus of this webinar is bridge programs in the Tampa Bay region, bridging acute care in our hospital's emergency department to treatment services for substance use disorder. We are looking forward to an incredible panel of healthcare systems, hospitals, and treatment providers. We'll have brief break to hear from one of our community partners before resuming the rest of the panel discussion. And then we'll close, of course, by hearing from a faith partner. We are so grateful for you all for joining us today. And so to begin, I would like to start with a video from Robert Cooper. Robert Cooper is a CCAR authorized recovery coach and the founder and president of 0 Hour Life Center. Rob hosts a recovery podcast with peer coaches called Fired Up for Recovery every Friday night. And you can join him and hear more from him and more about that. So let's play Rob's video now.
Hi, my name is Robert Cooper. I'm the CEO for 0 Hour Life Center, which is a recovery community organization. First of all, I'm a person in long-term recovery. I haven't had a drink or a drug since April 6, 2016. I love being in recovery. I really do. But I always wasn't this way. I used to be in my addiction for 10 years. I was a functioning addict. I first got introduced to cocaine when I was in the Marine Corps. I did 10 years in the Marine Corps. And it was one of those things where I was doing on the weekends. And then I was doing a lot of drinking too. And then my cocaine use escalated to doing during weekdays and then every day. I lost a lot of things from my addiction. But in my recovery, I gained a lot. Um, and, I think back on my journey. I don't take anything from it because it taught me a lot of things. It taught me what not to do, and it taught me what to do. But I can remember when everything hit the bottom, when I hit my bottom, and I'm thankful for my bottom because when I hit my bottom, I sat 7 months in jail, which gave me a time to reflect on myself and learn me and get away from all the distractions. And I can remember sitting in that jail and I said, I can be bitter or I can be better. And I started working on myself. I started working on my brain. I started working on me. And I was very productive in a negative situation. I can remember starting a Bible study, the first one ever in that pod I was in. I can remember in there counseling folks, trying to help them navigate the resources on the outside. And upon that, 0 Hour Life Center was born. And really, I had no clue about recovery. I just knew I was going to stop using drugs. But then upon me getting released from jail, I started learning about recovery. I started learning about my addiction. I learned everything that I could know, and I'm still learning. But one thing I can say is that if someone watching this, recovery is possible. Recovery is possible, and just get around good people. I'm not the person I am today without good people being in my life. So I thank you for letting me share a little bit of my story. And I like to end and say recovery is possible. Thank you.
Oh, thank you, Rob. What a moving story. And Rob really is a leader in the recovery community organization movement. And he heads up um, Zero Hour Life Center over, which is the recovery community organization for 5 counties, two of which are in the Tampa Bay region, up in Hernando and Citrus. And in addition to running an organization, he also serves on multiple statewide boards. And that message of hope really resonates with me. And I think that it's so important, especially as fentanyl is taking so many people, the lives of so many people. It's important to drive that message home that recovery is possible, and um, and that no matter where your substance use disorder brings you, whether it's jail or other consequences, that you can recover. So thanks, Rob. Now we are going to open up our panel discussion. I would like to introduce um, Erica to as a moderator this afternoon. Erica, can you pronounce your last name so I don't butcher it before I tell the world, read to the world your bio?
I sure can. It's Tarasovitch-Pollice.
All right. Erica Tarasovitch-Pollice is the Senior Program Manager at Central Florida Behavioral Health Network. She is an experienced program manager overseeing the hospital bridge programs with a demonstrated history of working in the mental health care industry. She is skilled in nonprofit organizations, crisis intervention, clinical research, behavioral health, and medicine. She received her bachelor's in social work from the University of St. Francis and her master's in clinical medical social work from the University of South Florida. Erica, where is the University of St. Francis?
It is in Fort Wayne, Indiana.
Wow, awesome. Well, we are lucky. So, did USF bring you to Florida?
Yes.
We're lucky that USF brought you to Florida. They brought me to Florida as well. And I'm really grateful that you're here and will be moderating this panel. Y'all, I have tagged in Erica because Erica, this is her area of expertise. And I wanted to make sure that our conversation today was robust and also in depth, so that those of you who are looking at adding a bridge program to your emergency department or emergency room, um, have your questions answered, and also for those just across the continuum of care, so that you can better understand the role that these programs play and the importance that they hold for um, people seeking to get treatment and get into recovery. And with that, I am going to turn it over to you, Erica.
Thank you. I'm excited to be here. Good afternoon to everyone. As Jennifer said, I am Erica Tarasovitch-Pollice, and I get to have the pleasure of introducing our panelists that are with us today, who really are the experts within these hospital bridge programs. And I'm excited that they're all able to be here today. Our first panelist that I'd like to introduce is Dr. Jason Wilson. Dr. Wilson is an emergency medicine physician with Tampa General Hospital. He serves as a core faculty member and associate professor in the Division of Emergency Medicine in the Division of Emergency Medicine and the Department of Internal Medicine at the Morsani College of Medicine at the University of South Florida. He also holds an affiliated faculty appointment with the Department of Anthropology at the University of South Florida. Dr. Wilson serves as the medical director for the clinical decision unit at Tampa General Hospital, as well as the associate medical director for the adult emergency department. In addition, Dr. Wilson is the research director for the emergency medicine residency program. Thank you for being with us today. Our next panelist is Elizabeth Cooper. Elizabeth joined BayCare Health Systems in September 2005 and is the nurse manager for Acute Services Program Coordination for Behavioral Health Administration. Elizabeth's range of service delivery includes oversight of the behavioral health ED within all BayCare sites, as well as management of the care coordination team members in the emergency department and community. Elizabeth collaborates with the interdisciplinary teams in the emergency department and inpatient behavioral health units in order to maintain operational issues surrounding patient flow, as well as monitor emergency department measures and indicators. Being responsible for developing and maintaining policies and protocols for new processes and improving existing processes, the team can ensure patients receive high quality, timely service and placement. Elizabeth is a native of Colorado and has been serving in the mental health population for over 30 years. Prior to her nursing roles, Elizabeth has experience in criminal justice, serving adolescents, certified medication, home health, case management, and quality assurance. Thank you for being with us today. Our next panelist is Brittany Mays. Excuse me. Brittany is an outpatient director at Operation PAR. She graduated with her MSW from USF in 2018, having chosen to work in the substance abuse disorder field for the past 6 years. She has worked in many roles and levels of care at Operation PAR, from overseeing the Access Center to her current position as outpatient director. In her current role, she focuses on overseeing their outpatient program, as well as multiple grants which help fund their homeless and housed clients with co-occurring mental health and substance abuse disorders. The Community Outreach Grant enables potential clients to seek immediate relief from connecting them with a peer specialist or case manager through the use of their PARBot technology. Clients can seek support and referrals, get screened for services, and most importantly, connect with a real-time person when help is needed most. Thank you for being with us. And finally, I'd like to introduce Heather Kaufman. Heather has been with Tri-County Human Services since 2001, and she is currently the Administrative Director of Outpatient Services. She is responsible for the administrative oversight of 11 outpatient programs, including specialty programs for children and families involved in the child welfare system. Heather began her career at Tri-County as an adolescent counselor and then moved on to become a field program supervisor, an outpatient manager, director of special programs, and corporate compliance officer until she entered her current clinical role. Over the years, Heather has conducted a variety of trainings in documentation, confidentiality, clinical practices, and compliance topics. She also does a variety of outside trainings in the community, has sat on several panels, and has worked with student interns from local colleges for years. Heather participates in several community committees, as well as some of the divisions of the Florida Behavioral Health Association. Heather is a proud graduate of the University of Florida, where she earned her bachelor's and master's degree in rehabilitation counseling. She became a licensed mental health counselor in 2003 and currently enjoys supervising licensed interns. Welcome to all of our panelists, and as I said, we're thankful that you're here with us today. We want to get started with our panelists by getting a good understanding of what hospital bridge programs are and the value that they provide to our communities in the continuum of care. Dr. Wilson, we'd like to start with you. And could you give us a brief overview of what these programs are and how they tend to work within our communities?
Yeah, absolutely. So just to level set and make sure people understand, if we go back in time, even 4 or 5 years ago, if a patient came into the emergency department with substance use disorder, specifically opioid use disorder, we really did not have much to offer those patients. Unless those patients were in acute overdose, there was not much we would do. Maybe we would give them a paper that had some of the partner organizations you see here today and say good luck. And what we know is that that led to deaths. And it did not lead to any help of the opioid crisis, and it has not helped us solve this as a community. We know that if a person presents to the emergency department with opioid use disorder and an overdose, their risk of mortality the next year is about 5%. That rivals coming in with chest pain and acute angina. And so we didn't have the right tools in our toolkit to help those patients. And so they were unseen. They really didn't rise to the surface of our clinical care. And what has really shifted now in the last 4 years, and I'll talk about the experience at Tampa General, but I'll talk broadly in terms of what bridge programs look like, is that we've really figured out what I think is starting to gel into a best practice of care, into building out a pathway, an assemblage of tools that we can use to treat patients at any point of time along the addiction spectrum, whether they're in withdrawal right now, whether they have an opioid use disorder at baseline, or they're an overdose. So wherever they are, or whether they're still using and need to make sure they don't get infections or die from use of drugs. So wherever they are, I think we're starting to develop tools to treat those patients. So again, 4 or 5 years ago, nothing. Let me tell you about what happens now in our ER. We had no one who had a Data 2000 buprenorphine waiver if we go back in time 4 or 5 years ago. We now have 13 physicians who have a waiver. What does this mean? This means that when patients come into our emergency department, if they're in withdrawal, we can offer those patients a buprenorphine dose in the emergency department and a bridging prescription for buprenorphine to allow time to establish care with one of the partner organizations like on this call today. When we first started that, it was really us trying to do this as both physicians and then also some of our graduate students we had brought in who have now finished and are actually running the program. Bernice McCoy and Heather Henderson, who are our PhD graduate students who run this program on a day-to-day basis, or PhD faculty who run this program on a daily basis. But we would try to do our best of identifying those patients back when we first started and try to get them to engage in care. And I'll tell you, at first, our success rates were not very good. It took a lot of physician time to identify patients, and it took a lot of work to engage that population. There was not trust yet. Remember, there are years of built-up stigma, and there are years of undone trust in this population. So what changed the ballgame for us was the bringing in of certified peer recovery specialists, really bringing in peers into our emergency department space, which I was skeptical about when we started, but has been the real game changer in this space, has allowed us a person who can quickly build trust with a patient who has opioid use disorder and can liaison between the patient and the care team. We utilize a scoring system called the Clinical Opioid Withdrawal Score, the COWS, and a patient who has a COWS score that's high enough where they're in withdrawal and we're not going to precipitate withdrawal, we offer those patients buprenorphine in the ER, and then we give them a prescription. We've worked really hard to make sure there's something's going to happen once that patient leaves the ER. And what we have found is all of our partner organizations, all of the people like are likely on this call today, have been very willing to see these patients outside of the ER setting. And so we've done a great job of establishing care spaces for those patients at some of our downstream partners, where they can either continue on buprenorphine or they may switch to methadone if that's the right drug for that patient. Again, all of this is liaison with peers and with our team sort of making sure that patient gets to care. What has really changed also as we mature is that this is becoming much more of a coordinated harm reduction program. We have the ED Bridge program, and that links really well to community resources like low barrier buprenorphine and even the syringe exchange in Hillsborough County. So that's a little bit of an overview, and I'll stop there to give other panelists time.
Thank you. I appreciate that. Heather and Brittany, from the other perspective, could you give us some insight into how the Bridge program works from the receiving partner side of it? Whoever would like to go first.
I'll jump in first. Good afternoon, everyone. So we have our hospital bridge program set up in 3 different hospital systems across Polk County. So it makes for interesting because every hospital system does a slightly different setup. But generally speaking, what it looks like for our peers is that when a person has been medically stabilized, the hospital staff will reach out to our peer and have them, come meet with the patient. And they will come and interact with that patient. Potentially, there may be some family members that may have come in with them that we will also interact with and provide information and support to. And our peers, we have some wonderful team of peers that will come in and quickly just kind of see what's going on. What's the defense like? Where's the person's readiness to possibly talk about even taking a first step towards help? And it kind of helps guide their tactic of how they approach the individual, the patient. And they will start off with just having having that initial talk with them. They will use self-disclosure as appropriate. They will just do a lot of engagement, providing a lot of encouragement, a lot of hope, letting them know that there is options outside of what they've been doing. And then depending on the outcome of that initial contact, which sometimes is a very brief, we'll take it to where they go. It may be that they leave it that the person is not willing to have that conversation at that time, and we leave information with them, and we call it planting seeds, where that person may reach out post-discharge to the hospital. We always leave that door open to any patient that our staff interacts with, that if they're not ready at that moment, but they can always reach out to us at any time down the road when they are ready. Or if they are ready at that moment, then our peer really then works hand in hand with the patient, with the hospital staff, with the family if they're present, to just help facilitate that next step, wherever that might be. It could be anything from, we have hospitals locally that want to move them to our detox facility, so we'll help facilitate that. Going on to the MAT services locally, outpatient-based services, residential, wherever is the need, they will just help and be there right with them, holding their hand sometimes, literally, to just help them take that first step. And then it just kind of goes from there, but that's the quick version of that overview of what it looks like.
Thank you. Brittany, would you like to add anything?
Sure. Thank you. PAR has different but similar approaches that are used. Operation PAR has peers located in multiple BayCare emergency departments. We also have PAR bots at these locations that can link patients to services. Between PAR and BayCare staff, those with substance use issues are identified. When a patient is in need of PAR services, a peer specialist would meet the individual at their bedside. They would meet them where they are at in their recovery. They engage their peers in a collaborative and caring relationship by providing support, by validating experiences and feelings, and to convey hope of recovery. If a patient is ready to take the next step, our peer specialist would reach out to a case manager or maybe an access center specialist to screen for a level of care. So when a peer specialist is not present at the hospital, we also have a PAR bot available to help link these individuals to services. A PAR bot essentially is an iPad on wheels. It has DoxyMe downloaded on it, and it provides telehealth. It allows PAR to connect to a patient via video conference. Once this client is identified, the PAR bot will be rolled to the client's bedside, where they will be directly linked to a peer specialist or a case manager that will engage with the client and screen them for the appropriate level of care. Whether patients are connected with a peer or a PAR bot, our goal is to get them out of the ER and straight to PAR, whether that be at our medicated assisted treatment program, where individuals can be treated for their opiate use, where we do have funding available for many of these folks. And we also have our detox, residential, and other outpatient programs. We are doing what we can to decrease barriers and to increase access of care for this vulnerable population. Yeah.
Thank you.
You're welcome.
Elizabeth and Dr. Wilson, since both of you have built so much of the infrastructure of the hospital bridge programs at BayCare and Tampa General, it's safe to say that bridge programs haven't always existed, and we all certainly know that there are hospitals and healthcare systems out there that don't have these programs. Could you help us understand what it might be like for someone who enters the emergency department from an overdose when there is not a hospital bridge program, or if the infrastructure is lacking within that program that exists?
I'll start. I think Dr. Wilson touched on it. In the past, patients would come in, our EDs would be jam-packed, full of the patients. They wouldn't get resources. They would be discharged back to environments that were conducive to, supporting the addiction process for them. So I think that without the infrastructure that we've created, and not only the infrastructure, but really working on culture change. Even within BayCare, we have multiple EDs with multiple providers. There's regional differences that promote big cultural differences, and accepting that addiction is actually a disease process, as if any other patient would come in, like Dr. Wilson talked about with chest pain. I mean, this disease process is superseding many of those disease processes that patients come into. So I think one of our biggest challenges when we started the Bridge program was how to incorporate it into the ED process. If we don't have the recovery support specialist working with the nurse and working with the physician and having that face to face, oh, hey, Elizabeth's my recovery support specialist. I know I can pick up the phone. ED physicians, at least within BayCare, have made it clear. I want to click one button, and I want to know that the recovery support specialist is going to see the patient, and then I'm going to get the follow up so I can make that final decision on where that patient might go. So that has been incredibly beneficial, for us building that infrastructure.
Yeah, Elizabeth said something really important there. It's this idea of one button. And, we've really tried to focus on creating an easy pathway. Clinically, things become much more pragmatically, put into throughput and practice when there's a obvious pathway built for it, and I don't have to reinvent the wheel, get social work involved, try to solve. You only have so much resilience and bandwidth to put a lot of building into a patient encounter, in a long clinical shift. So we have to have a lot of that infrastructure pre-built out in order for it to happen. And what we've learned is that anything in emergency medicine that's new, or a patient population you really haven't had a treatment option before, at first it feels a little scary and it feels a little strange. And so up front, you have to expect that you're going to need some resources to really both support and feed back to the physicians, to take the load off their clinical shift, and then also feedback the success stories. Those two things are how you get to the eventual hardwiring, where at first we had a lot of fear of writing buprenorphine. Now, if we don't have our peer around, people are like, "Where's the peer? I missed our peer. We need to see our peer." And hey, I wrote three bupe scripts yesterday, and very proud of themselves now. And it becomes just like any other disease state. So you got to 0 to 1 is always the hardest. And once you get there, the success stories will start to pick up the inertia, and then it becomes. I mean, this is not harder than treating complex sepsis or STEMIs or anything else that we treat.
Thank you. For all of our panelists, and whoever wants to start can begin, but what are some of the greatest outcomes or positive changes that you've seen through the implementation of the program from your various positions?
I'll start again. Just a little brief history. I mean, part of plugging me into this process for BayCare had everything to do with the process that we talked about. We're very outcomes based. Sam really has some great data, and I think one of the things that we've really learned from our data and our outcomes is that, this did start as an opiate pathway, but we have uncovered alcohol as really a very, very big form of addiction. A lot of our patients come in, with an intoxicant that is not an opiate. So really recognizing that and our cadence, understanding our cadence in the ED is fast. Decisions fast. We don't have time for 2 hours to wait for disposition on patients. And those, just building out that communication with our community providers so they can adjust their process to give us that opportunity to say, okay, yeah, we can take this patient, we can't take this patient, because then we need to move on to that next step. So our outcomes have shown us that the faster that we can work on the front end and then work with our community partners to bridge that gap, the more success we have when that recovery support specialist actually engages with the patient. And then the patient says, yes, I'll go to treatment. But if we have a large gap in time there that we sit and we wait, and can we divert that patient to a less restrictive environment, things kind of can spiral out of control a little bit, and we lose that piece of our process. So our outcomes really show us that we're really starting in the front end to divide out our patients that are opiate, our patients that have co-occurring disease processes, and then our patients who are just straight, chronically mentally ill. And then that helps us with throughput, and it helps us ultimately get our patients to the right treatment.
impactful story.
Thank you. Do any of our other panelists have anything to add?
I think what I would like to just jump in terms of positive changes that we've seen just from feedback from the hospitals we've been working with is that they have overall seen a general reduction in some of the ones that we would probably classify as the high need, high utilizers, the ones kind of constantly coming through the revolving door of the hospital ED. And, you know, especially at the largest hospital here in Polk, where I have 3 peers at, and they stay so busy in that very large hospital. We've had hospital staff acknowledge, you know, ones that they have seen every 2 weeks and every 3 weeks, and all of a sudden they're like, wait a minute, I haven't seen this person for a while. And what they came to find out is that we were able to successfully engage them to a placement, and they're in a residential center somewhere, or they're, you know, there's something like that. So we've been able to create those positive interventions. And I feel like this program has really allowed all of us to identify so early on some of these patients and really be able to have those initial interventions and touch these individuals that, again, in the past, we would have to wait till they showed up on the provider's doorstep, which a lot of times did not unfortunately happen. So helping break that cycle, I believe, has been a really good thing. And we're seeing just a lot of people, and we're hearing success stories. We've had our program up long enough that some of these people have circled back around to the peers and are calling them to let them know how good they're doing, which of course just, you know, lights up their world that they get to hear that type of stuff. So we're definitely seeing that.
Yeah, and I would say too, what's been pretty amazing to watch is we had a lot of physicians who really did not recognize addiction as a treatable disease state, and to watch the first time they give buprenorphine and see even in a few minutes a difference in what that patient encounter looked like to what that patient encounter becomes has opened up the imagination for all kinds of potentials. And I mean, really, this was not known to a lot of physicians before. This person who seemed maybe was a jerk at the beginning of the visit suddenly seems to be a pretty nice human being when they're not hurting. You know, like Elizabeth spoke to, I think what's really been pretty amazing too is how much this has allowed us to move into the construction of other pathways where we really didn't think we had many options either, co-occurring disease and infectious disease as well.
Yeah.
Thank you.
And we have had the opportunity to fully assess and develop our peer role at PAR. Having our peers share their experiences, their strength, their hope has led them to connect clients to resources and appointments to build momentum for their recovery. When we first started working with BayCare, we had 1 peer at St. Anthony's. Now we have multiple peers, peer specialists between St. Anthony's, Meads, Dunedin, and Morton Plant. We're looking to expand at another hospital with 3 more peer roles. In the past 2 years, our peer specialists have screened 588 individuals for services. They have referred 346 of those to treatment, and out of those, 212 individuals have engaged at PAR. Since the PARBot was implemented back in October, we've screened 95 clients, and we're still in contact with many of those. Overall, having the peer or the PARBot in the emergency department has increased access to care. Patients now have immediate access to a PAR peer, a case manager, or the access center specialist, starting off with just 1 peer and now incorporating technology to help link individuals. Has been a big change, and one that we view as being very positive, and we're extremely proud of. There's a need. We see the need in the hospitals. We see the needs that the communities have. There is a need for our peers to be at these locations, and there is a need for our collaboration. We all could not have done any of this without working with like Elizabeth and her BayCare team. We have worked collaboratively to get individuals out of their door and into ours, and it's been a team effort without a doubt, one that we're keep growing and keep building to better serve this population.
There are many pieces that come together in order to make these hospital bridge programs work, but the peers are definitely the heart of these programs.
Wonderful.
Jennifer, I'll send it back to you.
Thank you. Thank you, Erica, for moderating part 1 of our discussion. And thank you, panelists, for your insights on the importance and impact of bridge programs. This has been a really exciting discussion. And I love that we ended with the comment about the peers, because we really went back and forth as to whether to include peers on this call or do an entirely separate webinar just on peer support specialists. And we actually next month will have a focus on peer support specialists. We'll revisit our panel shortly, but in the meantime, I'd like to take a break and we see through this conversation that collaboration and communication is important. So we want to consistently highlight other organizations and initiatives. So if you would like to amplify an aspect of the work that you are doing, please let us know, and we're happy to highlight your work in a 3-minute spotlight during our webinars. For our spotlight this afternoon, I'd like to introduce Shelby Metters. Shelby is the executive director of the Florida Harm Reduction Collaborative. Shelby earned her Bachelor's of Science from Florida State University in 2015 and a Master's of Public Health in 2018 with a specialization in health policy and management. Prior to her current role, Shelby managed a statewide overdose prevention and naloxone distribution program through the Florida Department of Children and Families. Shelby resides right here in sunny St. Petersburg, Florida, and plays an active role in St. Pete Pride and is a proud harm reductionist. Shelby?
Hey, thanks for having me, Jennifer. I really appreciate you having me on today. And I would just like to take a moment to highlight our collective statewide mail-based naloxone distribution program. And I know I have a few slides, but I can just quickly pull them up just to read what's on them on my end. But we did pick up the statewide mail-based naloxone distribution program back in March. So since then, we've seen some awesome numbers come from this. So I'm going to just kind of go over a few numbers real quick. Since March 2022, we've distributed 327 kits mail-based, and we've had 37 reversals self-reported. And then requests to date, we've had in the last year, 15% of people experienced an overdose themselves. 65% witnessed an overdose themselves in the last year. And 39% did not have health insurance when they requested a free Narcan kit. So we have made this a QR code. It's easily accessible. You can just, I'm going to supply the link here, and we're relaunching our website, so you'll be able to easily find the link to request a free Narcan kit. We work with Next Distro, who's an organization out of New York who runs these programs all throughout the U.S. And then you can also, through our website and through Next Distro, report an overdose. And then again, the data we're seeing from this, we see the barriers to why they're not receiving naloxone or harm reduction services in person, whether that's financial, they're unsure of local resources or how to find local activities going on, and then lack of transportation. So we really just want to, aim to decrease the stigma, increase community connections, and all of the kits we mail out. We provide local resources to the SSPs. We provide local resources to the recovery community organizations. We provide just the iSaveFL locator, so they know how to get it in person if they need to find in-person naloxone, and really just, increase these community connections. We want people to seek treatment if they're ready for treatment, or if they continue to use drugs, we want to meet them where they're at to provide the needed services, just like naloxone. So I appreciate you letting me highlight the program today, and I'll provide my email as well if anyone has any questions. And we're looking forward to relaunching our website at the end of this month so you can see all the resources we have available. So thank you, Jennifer.
Absolutely. And Shelby, just quickly, if somebody wants to make sure that their program or their agency is located on your resource page that you mail out with naloxone, how do they get that to you?
Yeah, absolutely. So right now we're starting to collect all of these things. So, we have some great data that comes in on the back end from who's requesting these kits. So we have the county data. So for each, I kind of do it by county right now, but it might even get more specific than that, by city, hopefully. But I'll provide my email, and you can just shoot me an email, and I'd be happy to get some resources from you for anybody to include in those kits.
Excellent. Thank you so much, Shelby. And a big thank you to the Florida Harm Reduction Collaborative for the work that y'all do across the state. It's very, very needed. So
You're muted.
Thank you. I don't know where I got muted, but Shelby, I thanked you and the Florida Harm Reduction Collaborative. And then I said I would like to reintroduce Erica Tarasovitch-Pollice and our panel to discuss some of the challenges and best practices in implementing this best practice, which is the Bridge program.
Thank you. So for this second part of our panel discussion, we want to explore a few questions around what works best and how to replicate these successes with ongoing hospital bridge programs within communities. Starting with Brittany. Brittany, can you tell us what you feel makes a good receiving partner and what qualities in the healthcare system that contribute to a successful hospital bridge program?
Sure. As a receiving partner, collaboration, communication, and relationship building at each level is key. The staff that are the boots on the ground doing the work, outreaching, meeting with clients, patients to get them engaged in treatment, they're all working together as a unified front. The leaders, the directors, the managers, it is important that we are all working together as a unified front. We all are joining together to achieve a shared goal, which is to get these individuals into treatment, into our MAT programs, to treat for opiate use, to get them into services at the appropriate level of care. Ongoing feedback about what is working and what needs to change to better serve our clients is a must. At PAR, we meet weekly, if not more internally, to discuss processes, barriers, criteria, expectations. Not only do we meet with staff that we directly supervise at an outpatient level, we also meet with other PAR programs weekly to discuss what has been successful or challenging while trying to get these individuals into services. We're always looking for ways to increase access to care, and we do our best to demonstrate that our program adds value. The qualities in a healthcare system that contribute to a good bridge program is very similar. Collaboration and relationship building is key. Having an open line of communication about what is and is not working on both sides is key for a successful program. It's helpful when all involved show patience and flexibility when screening and referring to different levels of care. PAR meets weekly, if not more, with BayCare to discuss referral status, to staff clients, to discuss successes and ongoing challenges, and partnership is key so we can all work as a team to bridge the gap between one location to the next.
Thank you. For all of our panelists, what are some of the challenges and best practices in coordinating between the emergency department and the follow-up treatment?
Yeah, so I think having pre-established infrastructure for this, before you get the first patient, making sure you've really had a lot of good meetings with your potential community partners. I think that's super important because what you're hearing here is you need to have an open line of referral, and you need to have really high reliability that patient's going to make it to the referral space. That's critical. Some of the challenges, we're talking about this over in the chat, is it may be a little difficult that first time you get a peer placed into a hospital space, and that could be difficult with any type of new position in a hospital space. But working around the evidence for that, showing the evidence for that, moving that peer into the emergency department itself under ER leadership was really a big game changer in getting support for that. So just understand there may be some infrastructure built around peers as well. In best practice for us, we really started to treat this patient population just like we do with any other clinical patient population, which means we round on the patients. And, rounding can be done in a lot of different ways. Traditionally think of like House walking around with this, big team of, physicians and residents and everything, but we round by email, and we round with our, with Cove and ACTS and our peers and our partner organizations. We round every day. So all new enrollees, all new screen fails, any issues that are having, and we try to solve those as a leadership team with our frontline peers as quickly as possible. So those are some of the best practices we've developed over time that I think have been really successful for hardwiring the program.
And I think from BayCare perspective, we were fortunate, with Gail, our vice president, who is a champion. I mean, she very much supported this program and said, do it. Let's make this right. And so, certainly the challenges in the beginning were just setting up the processes and getting to know the community providers and having providers work together. I mean, we have two different providers working in one of our EDs. We have ACTS and Cove who actually work together in the best interest of the patient in one of our EDs. So that's been fantastic. And then just understanding, I guess, some of the things that Brittany has talked about in our weekly meetings, understanding how the criteria from county to county is different. Tri-County has a different criteria of acceptance of a patient than maybe PAR does. And so just really wanting to take a look at that and then involving all the other important players, our high need, high utilizer teams, PIC, MHU, law enforcement, really drawing in the big crowd to have the conversations because we're not the only touch points, for these patients. But then just keeping it simple and getting back to that process and those basics in the ED. One button, we need to move the patient to the right treatment, understanding each other's cadence. We need to move quickly, and the communities want to make sure that when they do accept the patient, they can treat. So those are some of the really quick and easy examples. But like Brittany said, the communication and the weekly meetings and the staffings and understanding why patients are continuing to come back and what we need to do different in their next visit to minimize those visits and support the community treatment has been key for us.
What I would like to add in would be, I very much echo the same thing with the open communication, extremely important, and working through when something isn't going right, and then obviously also celebrating the things that are going right. The building the relationship with the hospital staff, I would say from our perspective, from being a provider in 3 different hospital systems, we had to be very flexible. And so if you're a provider that's going to, potentially work with different hospital administrations and such, I had to kind of navigate through that because every hospital has everything from different credentialing for our staff to be on site to, working through building those relationships with the on-site hospital staff or our peers, scheduling processes. I mean, every one of our systems is slightly different, but we're still getting the same end result. So having a lot of flexibility and being very accommodating and understanding of the different nuances of the different hospital systems, because in the end we're all there for the same purpose. It's just kind of working through all of that. So it's a best practice, but yet can be a challenge at the same time, I think, a little bit. I would say we definitely got past all of that at this point, and we have built, I feel, very good, strong relationships because we were with BayCare, we're with Advent Health, and then we're also with Lakeland Regional Health, which is the very large one here at Lakeland, where I have 3 pairs that sometimes, I will say, run all over that hospital at times, because we found that it's not just popping up in the ED, it's in their behavioral health unit and different medical floors when they're identifying those with substance use disorders and the opiate use. So at this point, once the word spread through the hospital, our peers pretty much get their steps in every day. Definitely.
Yeah, and some of our challenges we have encountered is not having immediate services to some of our programs at PAR. At times, our detox and residential programs may not have availability, or a client may not meet criteria for the program and is found not appropriate. And during these times, our peers and case managers attempt to refer the client to maybe another PAR program, such as outpatient, or to other facilities within the area. We do our best to communicate availability and exclusionary criteria to the hospital, but there may be times where we don't get immediate response from our medical and clinical teams at PAR due to some individuals having extensive medical history or high mental health that need to be reviewed a little more in depth by our review team. We may need additional information at times, maybe status updates on the client to see if there's stable additional clinicals or whatnot. And we're well aware that at times that can be a bit time consuming. There's much to consider when teams review for appropriateness at each PAR program. One of the best practices, we try to close the feedback loop with all parties involved, give status updates on the individuals that are referred. We're aware that at times the hospital is waiting for an answer from PAR. If someone is found appropriate and there is availability, we try to inform BayCare as soon as possible so that individual can be scheduled for the next available appointment. Whatever opening that may be. We have set aside appointment slots just for the hospital referrals for our detox program to help increase access to care. When clients are not found appropriate, the hospital needs to know as soon as possible so they can plan accordingly on that patient's discharge. PAR's medical team is working real hard to make the screening process easier and to inform those referring individuals to our programs of the admitting criteria. And again, this is when good communication and collaboration is key to provide the best care for these individuals in need.
Thank you. I think it's always helpful when we're doing lunch and learns like this to know not only the successes, which we all want to celebrate, but also some of the challenges that the experienced bridge programs have encountered, so that, you know, everybody can kind of know what to expect and what is out there. So I appreciate everyone's input. Heather and Elizabeth, you guys have each have a hospital that is a little bit more rural than some of your other hospitals. And can you kind of speak to what other providers who are looking to expand or improve in this space within the rural counties, whatever recommendations you would have for them?
I would say one thing that we run into, and I would say BayCare has done a fabulous job working with it, and the other hospitals that we have in the east side of the county, is recognizing transportation challenges, which you will find specifically in the rural areas. When they leave the hospital, let's say if they are needing to go to a detox or a residential, or maybe whatever it might be, if they do need to go from the hospital to another entity, what the options are, because when you're in areas that does not have public transportation, or if that's maybe not appropriate for the just put someone on there, what are the options, either through the hospital system or the county funded type transportation programs that are available. So we've kind of used all the above and just work closely with the hospital to just see what they can do to help get that appropriate transition out of the hospital to where they need. That can be a challenge, so just being aware of it. And then I would say probably also echoing Brittany a little bit about, we do run into times where the closest services available, the beds may be full. And detox might be full, or a residential program, or whatever the case might be, of whatever the hospital has identified is the need of that person to where they need to be transitioned and transferred to. So what our peers have done is really stepped outside even just our area, and have gotten to build networking and relationships of providers all across the state. And I will say, at this point in time, we're not necessarily just saying they have to come to Tri-County. We want to get them placed to wherever is the best place for that person to get the care they needed when they need it. And if there is where we cannot have a bed at that moment, because sometimes it doesn't work out that way, where can we get them placed? And our peers have successfully put people, honestly, across the entire state of Florida, not just the Suncoast region and Circuit 10 here, but everywhere from the Panhandle to South Florida, and they have been able to just work really good with the hospital and the social workers and stuff to just help create and facilitate that transition. So I think being aware of not just what's locally and in rural areas that may be limited, to what else is out there to still get the help that person needs.
And I would just add, just connecting those dots, find out who are the entities that are bringing the individuals to your door. Is it law enforcement? Is it family members? And then, doing some educating in the community and coordinating with community providers. Is law enforcement dropping off at an ED because it's quicker and it's faster, and they're not met with as much resistance or concern that the patient's going to be dropped, and then they're not going to stay for treatment. So there's all kinds of factors that just really go into building that process, but really finding out, uncovering those stones. What is the culture? What is the process? Who goes where, and why did they go there? We've established some programs in our Winter Haven Hospital where some of our patients, they're great programs, and we have some great people that work there. And even our recovery support specialists, some of our patients are now coming back to the ED because they want to see those folks. So then we had to take a look at that and turn that around and say, okay, this is good, this is great. They've got a touch point, but this isn't the appropriate place to do that. So then reaching back out to the community and spreading that out, and again, connecting those dots. And just if they come to us, we bump them back to somebody else. If they're not appropriate there, they bump them back. Just sort of being that full on wraparound services is really, I think, key.
and I think I'm hearing some of this from PAR, but I think what's been really important from physician side, from provider side, is the CMS waiver for telemedicine and telehealth, and that really opens up and expands our ability to reach not only rural populations, but disabled populations, homebound populations, other people who just can't access care. So from a physician standpoint, there's pay parity around telemedicine now, and I can also write for buprenorphine through a telemedicine encounter. So those are important things to consider if when you're involving your physicians and providers.
Erica, I think you were muted.
Thank you. Sorry, I was just passing it back to Jennifer.
No, and I want to, Erica, thank you and thank all of the panelists today. And we have come to the end of our presentation. However, when we do the follow-up email, what I'll do is I'll make sure to also include some resources that if you want to learn more about this best practice and go even more in depth, that you have the resources by which to do that. Before we end today, I want to again thank Jason, Elizabeth, Brittany, and Heather for participating in the panel. And I'd also like to introduce Imam Hassan Sultan. Imam Hassan Sultan is currently the president and founder of the Muslim Connection community organization that provides a safe space for all through educational, youth, and leadership programs. TMC aims to advance the prophetic mission to provide a compelling, convincing case for Islam to empower, educate, and mentor others to share their faith. Imam Sultan, thank you for joining us.
Thank you for having me. So I do thank you guys for having me here today towards the end, and it was an honor to listen to what everyone had to say. Just a little background. Every Thursday we have this thing called the Lifeline, where different imams, pastors, people from different health backgrounds, and also PHAC and USF discuss different things that have to deal with mental health and dealing with that, those aspects. So one thing I do want to mention in regards to what I've heard today is a lot of this stuff. I think we are stronger together. And a lot of times things that separate us are things that are not in our control, whether it be corporations or whatever it may be. And we see that when we work for the common good, it brings good for all of humanity. And also, one of the greatest satisfactions that can come to a human being is a sense of being able to help others. And individually, we can do it, but also together, it makes us stronger. So I do appreciate seeing the networking that's happening and that's taking place, and I do hope that this continues for future. One more thing I'll mention is that we as humans, we all have basic instincts and needs, regardless of faith and culture. Everyone has to eat, they're chewing to sleep. Everyone has emotions. Everyone gets angry, sad, and happy. And everyone also needs the basic necessities of life, of food and shelter. And also everyone has this thing, innate nature within us, that there's something higher than us. And in order to satisfy these instincts, we believe that there has to be a system in place to be able to tell us and define how do we go about it. And I believe firmly that to define morality objectively, it has to be done through faith, because everyone then will have their own opinion. And one of the things that we're told about morality is how to deal with each other as humans. What are the rights of neighbors? What are the rights of your parents, siblings, co-workers? And we're trying to always improve on our relationship with one another. And one of the things that they say is the highest level of being grateful is to show gratitude, right? And gratitude helps lead to be patient. So, but then also someone asks themselves, why should I help others if there's no money compensation, or there's no reward immediately. And this is where, you know, the idea of compensation comes from a higher source is a great feeling to have, because it reminds you that no matter what you do now, but the reward that you get internally, right? No matter if I was to pay $1 million to feel a certain way, I would not be able to feel that unless I actually was involved in helping others. So this is something really, one of the greatest things you can do is to be a service of others. So I'll close with a closing invocation. In the name of God, the most gracious, the most merciful, the extremely merciful, I pray, God, that He alleviates the pain of those who are suffering, those who are going through pain and hardship, and anyone facing any type of sickness, for God to bring ease and cure their disease. Ask God to accept and make us sincere towards another, and remove feelings of animosity, hatred, and jealousy towards one another, and replace it with understanding, compassion, love, and tranquility. I ask God that He bestows upon us His mercy, that He unites our hearts for the greater good, that we work together, and God removes anything that may hinder our growth. And we ask God that anyone right now on this call, or is anyone who's participating, that if you have any type of difficulty, whether it be financial, stress, relationship, that God guides us to make the best decisions. And God continues to use us for goodness all around the world, and makes us a source of blessing, whether it's in our houses, in our job, our workplace, that God makes a source of goodness wherever we are. And with that, I close. Thank you. I mean,
Thank you, Imam. And thank you all for joining us today. I have inserted a link in the chat, and this is a survey so that you can give us feedback of what you want to hear more of, what you want to hear less of, and what topics you want to discuss in future Link Lunch and Learns. We will be taking some time during the summer to launch some new strategic initiatives. So our next So stay tuned for our next Lunch and Learn. And in the meantime, please mark your calendars for June 28th, 2022 at the Cuban Club in Ybor City in Tampa. Senator Rouson will be sharing his story, and there'll be lots of opportunities for leaders on this, on the opioid crisis to network, meet each other, and talk, have more conversations. So we look forward to seeing you all there. And in the meantime, we will be following up via email. Thank you all.